welcome everyone to the first Society of Skeletal Radiology Medical Student Research Symposium. We are very excited to present 13 amazing abstracts from 13 amazing medical students throughout the North America region and Central America. Um, I don't want to take too much time away from the speakers, but I just wanted to let you know it's been a few months in the making. All these folks have submitted abstracts which have been reviewed and accepted on their merit. And we are looking forward to learning from these hopefully future musculoskeletal imagers. It's very important to start this pipeline early for multiple reasons. So without further ado, we will get the party started. I'd like to first introduce our moderators. We have four moderators who have volunteered their time on behalf of the Strategic Advancement Committee and the Diversity, Equity, Inclusion Committees. So the first two moderators we'll have are Dr. Andrew Ross, who is an Associate Professor of Radiology at University of Wisconsin. So thank you for joining us. Dr. Barry Hansford as well, Associate Professor at Oregon Health and Sciences University. And then after 1 hour at approximately 8 o'clock, we're going to hand off an unannounced handoff to the next two moderators. Joining us are Dr. Aaron Weiss, who's an assistant professor at Mayo Clinic in Arizona, and Dr. Shruti Suresh, who is an assistant professor at University of Utah. And stick around at the end. We'll have an announcement for the most outstanding of the outstanding abstracts. And without further ado, I will hand it over to the moderators. Thank you again for joining us, and we look forward to the presentations.
Thank you so much, Naveed. Appreciate it. I'd like to introduce our first speaker today is Garrett Barfoot. Take it away.
Thank you so much. Appreciate the opportunity to be here with you all. 1 second. My name is Garrett Barfoot. I'm a fourth-year medical student, and I'll be presenting on the spectrum of sports-related glenoid labrum pathologies. Special thank you to my mentor, Gitanjali Bajaj from University of Arkansas, for helping me prepare this and other works. Okay, we have no disclosures. Our goals and objectives for today are to provide imaging examples of common labral injuries, highlight key imaging features, and briefly review biomechanics that contribute to these pathologies. The background is these are pretty common injuries. I don't know why the text is all of a sudden not showing up, but long story short, acute injuries are common in contact sports like wrestling, football, rugby. Chronic injuries are common in throwing sports like baseball or javelin, also common in gymnastics, swimming, and tennis, where there's a lot of overhead repetitive motions. We will describe what the lesions look like, key points to include in radiology reports, and factors that are important to managing clinicians. This is the anatomy of the glenoid labrum. We are going to focus on three key areas of common injury: the superior region, where slap tears and posterior superior impingement occur; the posterior area, where Bennett lesions, batter shoulders, glenohumeral internal rotation deficits, reverse Bankart lesions, and Kim lesions occur; and anterior inferior region, where Bankart lesions and some of the other anterior inferior pathologies occur, such as Perthes lesions, ALPSA, which stands for anterior labro-ligamentous periosteal sleeve avulsion, GLAD lesions, which stands for glenohumeral articular disruption, and Hagel lesions, which stands for humeral avulsion of glenohumeral ligament in the inferior area. This is an image demonstrating a 30-year-old male that has pain with overhead activities. This image demonstrates posterior labral hypertrophy. That's an adaptive response, and retroversion of the humerus in the glenoid. And this is meant to demonstrate that not all labral abnormalities are tears, so keeping that in mind. But that being said, some of these labral abnormalities can lead to pathological tears, such as this 40-year-old tennis player with right posterior shoulder pain. And this is a retroverted humerus that's also demonstrating a posterior labral tear. This is a 14-year-old baseball player with chronic shoulder pain. These images demonstrate a posterior labral tear caused by repetitive subluxation. And this is a batter's shoulder. So this happens in the lead shoulder of batters that occurs from repetitive subluxation during batting. This slide goes over the mechanism of injury a little bit more in detail. And most of these injuries are treated conservatively, and surgery is reserved for those cases where conservative treatment fails. This is a 20-year-old baseball player with right shoulder pain, recent loss of velocity. And what is demonstrated here is posterior labral contraction. And this is called glenohumeral internal rotation deficit, or GERD. And this is commonly seen in overhead athletes. This next slide goes over some of the kind of pathophys a little bit more in detail, where the throwing shoulder typically has a loss of 20 degrees or greater compared to the non-throwing shoulder. And there's a posterior contracture along that capsular ligament. The treatment for this is aimed towards stretching and strengthening programs, and capsulotomy, or resection, surgical section of that posterior contracture, is reserved for those that fail that stretching and strengthening program. Slap tears are also commonly seen with these injuries. This is a 19-year-old right-handed college baseball pitcher with right shoulder pain. Let me see where I've got here in my slides. And this is showing the ossification in the plain film off to the right near the posterior glenoid rim, and this is a Bennett lesion. This is also common in throwers. Looking for ossification of the posterior glenoid capsule on the insertion point on MRI or plain films. Plain films can visualize that or distinguish that a little bit better sometimes. Management is conservative and less symptomatic or problematic for throwers. This is a 17-year-old softball player with shoulder pain, and this is demonstrating a reverse Bankart lesion. And that's the yellow arrow where it's pointing there. This is also showing a separate injury that's a bony lesion that we're not discussing for the purposes of today. That's very common with the reverse Bankart. This is the mechanism of action for a posterior shoulder dislocation, which commonly causes a reverse Bankart. So the flexion, internal rotation, and the axial load along the humerus. The clinical management of this is depending on the extent of the tear detachment, and surgery for these is pretty commonly indicated. These are Kim lesions, which is another type of lesion to the posterior glenoid labrum. These are just partial avulsions compared to the full tears of the posterior Bankart. This is an image from a case report that's demonstrating that partial avulsion where that white arrow is. And these, again, can be commonly surgically managed depending on the extent of instability. If there's not a lot of instability, they can be conservatively managed without surgery. Anterior instability is typically caused by anterior dislocation, which happens with what they call Aber position, or abduction and external rotation. And these are some of the bony osseous injuries that happen with anterior instability. And then these are some of the soft tissue injuries that we'll be discussing. We won't be discussing rotator cuff tears, but just focusing on the labrum. So these are some of the common anterior inferior lesions. Letter A is demonstrating the Bankart lesion. Letter B is the bony Bankart lesion. C is a Perthes lesion. D is a Alpsa lesion. And E is a GLAD lesion where there's the articular surface involved. And then F is the Hagel of the inferior glenohumeral ligament. And these are some of what the imaging looks like for each of these. So the soft tissue Bankart, the Perthes lesion, Alpsa, all at the anterior inferior region. And I wish we could blow these up and look at them and spend a little more time with them. But these are the things that the surgeons are looking for when evaluating clinical decision-making based off of the radiology report. So if there is bony involvement, which these labral injuries seldom happen in isolation, there's either cuff tears or bony lesions associated with them. So if there is a Hill-Sachs lesion or reverse Hill-Sachs, like was imaged with or demonstrated with the reverse Bankart lesion, they want to know what percentage of the humeral head is involved. With the anterior infralabral capsule injuries, they want to know the extent of the tear or tissue involvement. Bipolar lesions with on or off track, that's another bony lesion, and then associated injuries with fractures or cuff tears or nerve injuries as well. These are slap tears, common in, again, overhead athletes, swimmers, throwers, tennis players. These are the common mechanisms of injury. So we talked about throwing a little bit. Rotator cuff tears can also contribute to these very commonly. And then impingement, internal impingement, whether anterior impingement or posterior impingement, are common mechanisms of action for, or mechanisms of injury for slap tears. This is a type 2 slap tear in an 18-year-old female with left shoulder pain that's worse with overhead motions. This is the most common type. This goes over all the different types. There's 10 different types of slap tears. The most important thing to note is just the extent of the involvement, whether it's the anterior rim of the glenoid, if it extends into the glenohumeral ligaments, if it's complete avulsion, or the different structures involved. And that's what they don't care so much about the naming or numbering. They just care about the tissues involved. This is posterior superior impingement, or PSI, and again, common in throwers. This is what it looks like on imaging. You can show partial thickness tears of the posterior supraspinatus and anterior infraspinatus tendons right underneath, along with a posterior superior labral tear. So it's those rotators, external rotators, that are commonly torn in association with those. This is kind of the take-home message, that understanding how these injuries happen, what the treating clinicians are looking for, are the most important things to do, and what we need to include in our radiology report. And those are the references. Thank you.
Thank you, Garrett. That was great. I think for the sake of time, maybe we'll move on to the next presenter, but very comprehensive, excellent review. Thank you.
Yeah, Garrett, great job. Quick question for Naveed. Are these PowerPoint presentations going to be made available either at the SSR spring meeting or in some other forum?
That is a great question. I do not have the answer to them, but I am not opposed, as long as our speakers are not opposed to us sharing them.
Sounds good. So stay tuned, because I know Garrett put a lot of work into developing a real tour de force review of the labral pathology there. So thanks for that. Just a reminder to our attendees that you are welcome to put questions in the chat. There's a Q&A function on your toolbar. You can enter questions there. We have limited time for questions, so having some of those go in the chat, and then the presenters can answer those even after they're done with their presentation in the chat. So I encourage people to be putting questions in the chat, and presenters, keep an eye out if people are asking you questions to address those. But our next presenter is Hannah Beeler, and I'll turn it over to you.
Hannah, yeah.
Thank you. Oh my goodness, let's see. Gotten myself a little bit mixed up, but there we go. Can you guys hear me okay?
Yeah, I can hear you, and we're seeing your title slide right now.
Beautiful. Well, hello everyone. My name is Hannah Beeler. I am a medical student at WMed, and I have recently had the privilege of working with some just incredibly talented radiologists over at Wayne State University in Detroit. And we were working on a case report about hereditary multiple exostosis, which is commonly referred to as HME. And today we're going to be reviewing a young girl's experience with HME and the role radiology played in her disease progression and intervention. And I know we don't have a ton of time, so I'll just jump right in. I have no disclosures. I wanted to include just a very brief overview about HME before talking about the case. So HME is defined as multiple cartilaginous bony growths that generally arise around the metadiaphyseal regions of the skeleton, but they can develop anywhere on the skeleton. It is an autosomal dominant condition, so you'll often see it running in families. And although this disease does have 95 to 100% penetrance, the severity of disease is really quite variable. For some, they're not diagnosed until these lesions are found incidentally on imaging, and others have a very severe disease course where the growths can cause vascular compromise, neurological issues, and just a myriad of other potential complications. So our case starts with a young 6-year-old girl whose parents brought her into a pediatric orthopedist after they noticed she was limping after playing. And she doesn't have any pertinent medical or surgical history herself, but her father does have HME. So when the physician was doing her physical exam, they could feel some bony growths or prominence around her knees. And when she stood up, she was a bit knock-kneed and maybe had slightly reduced range of motion. But other than that, was a very healthy little kiddo. But given her history and her family history, they went ahead and just decided to do some imaging. So x-rays of the pelvis and the lower extremities confirmed the diagnosis of HME. There was multiple osteochondromas present around the growth plates on both of her knees, and very obvious genovalgum can be seen here as well. I know it can be a little hard to see the growths on this image, so you might have to take my word for it here. I'm going to go ahead and sum up about 12 years of her history for our patient, basically ages 6 through 18. She was maybe not as fortunate as others who have HME and had a relatively severe disease progression. She had neuropathy both from HME itself, but also from surgical complication, in addition to scoliosis, skeletal deformity, and just quite a bit of pain, which had a huge impact on her quality of life. And throughout her medical journey, she received routine imaging, both to track current growths, but also to intervene early on new growths before they became severely symptomatic. And honestly, imaging just became part of her regular follow-ups. And when I was reviewing her history and talking with the radiology team, it really became apparent that radiology being a key player in her team made a huge difference in her outcome. And I pulled some imaging from her medical records that really demonstrate both the local and systemic effects HME can have on the skeleton, and I'll take you guys through some of the cool ones now. So this first image really demonstrates the scoliosis she began to develop in her preteen years, which is secondary to the progression of her HME. And at this time, she was also bracing her ankles and her knees due to pain whenever she was having to participate in sports. And future images that were taken after this showed that there was multiple osteochondromas in her pelvis, which induced a pelvic shift, pelvic tilt, sorry, and a truncal shift, which when we think about the anatomy there, kind of explains her scoliosis a bit. And these truly are just my favorite images. I think it is just so fascinating to see these reconstructed images of her left lower extremity. And there are near identical ones of her right lower extremity as well, and suspected similarities of her upper extremities. And I think it's really obvious to see the presence and the severity of all the growths. And you really can only imagine like the impact that this would have on her life. And I think it's worth mentioning that this was after numerous surgical interventions for herself. And the importance of these images is that this, even though she was complaining of a bit of pain, here was where they identified that there might be more misalignment than they thought. And it kind of triggered a cascade of far more aggressive surgical intervention for her. So this image was taken when the patient was 13 years old, a little bit before she started to reach skeletal maturity. These images picked up on a leg length discrepancy before her care team was highly suspicious for one. Leg length discrepancies are very common in HME. If you think about the pathology of the disease, it does make sense. Nonetheless, still very important to document and keep track of. So I've mentioned this a little bit before, but really providing quality care to our patients involves looking at their care in a very holistic manner, and quality of life is such a big factor here. Certain medical conditions like HME might have more of an impact than other conditions do, especially in the pediatric population. And being able to tailor the care team and the plan to accommodate this is really important when thinking about outcome, not just in terms of pathology, but the patient as a whole. One key takeaway I really, really wanted to share tonight that I think this case does a really good job about talking about is just the importance of a multidisciplinary team when caring for patients with HME, or really any complex medical condition for that matter. and at least in my experience, I think it's often to think about radiology as just like a resource that you can pull off the shelf and use when you need it. But for some patients, radiology should be incorporated as a primary discipline in the care team, just like a PCP would or a surgical specialty. And for this patient, this made a huge difference in early diagnosis, aggressive intervention, and had a very positive impact while she was developing through her adolescence years, and will likely have an incredibly positive impact on her care as we move forward. That's all I have for you today. I know this was brief, but I could talk about it for hours. Here's some references if they are of interest to anyone. And if anyone has any comments or questions, I'm happy to discuss, and thank you all so much.
All right, Hannah, great job. I really like how you emphasize that for these complex disease conditions, it does really require a multidisciplinary team-based approach, and radiology is very much a part of that team. And I've certainly seen that time and time again in my career. We do have about 30 seconds here if anyone has a question. If not, you can also put it in the Q&A function in the chat, and the panelists can take a look there to answer them. And let's see,
Yeah.
Navita's asking if patients with, oh yeah, do you see that there, Hannah?
I do. That is such a great question. From the research that I saw, malignancy is rare. It is a possibility, which is why these patients, even if they are asymptomatic, tend to be monitored more aggressively than just the average patient. But it is a possibility, as with any growth, but very rare.
Thank you.
Yeah, of course.
All right, excellent. Thank you very much. Our next speaker here is Regan Bayer. Take it away.
Okay, let's just make sure I have control of the slides. Good. And is everyone able to hear me okay? Fantastic. Thank you again for the opportunity to present today. My name is Regan, and I'm a third-year medical student at the University of Wisconsin School of Medicine and Public Health. I'm very excited to share my research titled A Novel Radiographic Parameter of Anterior and Posterior Acetabular Wall Intersection with the Sourceal and its correlation with surgical management, specifically in cases of borderline hip dysplasia. These are the disclosures for our research team, none of which are relevant to today's talk, and I personally have no disclosures. Beginning first with some background information regarding hip dysplasia and femoroacetabular impingement syndrome, or FAIS, both of which are relatively common etiologies of hip osteoarthritis. Hip dysplasia is a condition of joint instability due to reduced acetabular coverage of the femoral head, and it's commonly treated today with periacetabular osteotomy, which is an open surgical technique to improve lateral coverage of the femoral head while preserving continuity of the posterior pelvic column. Contrastingly, FAIS is a condition of excess bone, resulting in abnormal contact between the proximal femur and the acetabulum, and it is commonly treated today with bony debridement via a minimally invasive hip arthroscopy approach. The gold standard of radiographic measurement for the diagnosis of dysplasia is the lateral center edge angle, or LCEA. Shown here, the LCEA is measured on AP pelvis radiographs as the angle between the longitudinal axis of the pelvis and the lateralmost aspect of the sourceal, which is the sclerotic roof of the acetabulum. Based on LCEA, the diagnosis of frank dysplasia, borderline hip dysplasia, or femoral acetabular impingement syndrome can be made. And this has implications for surgical treatment, as patients with an LCEA of less than 18 degrees are typically indicated for a periacetabular osteotomy, whereas patients with more normal lateral center edge angles are typically indicated for hip arthroscopy. It is less clear for patients who have borderline acetabular dysplasia because they may have significant joint instability, which is not represented by their LCEA and would require a PAO for adequate treatment, or they could have a primarily impingement mechanism, which could just be adequately treated with minimally invasive hip arthroscopy alone. That brings us to the continuing problem that borderline hip dysplasia is for orthopedic surgeons. It's a challenging diagnosis for surgical decision-making due to this lack of reliable methods for identifying underlying joint instability. So the purpose of this current study was to develop a new radiographic parameter to better quantify anterior and posterior acetabular wall coverage, and one, determine if that parameter correlates with surgical management, meaning periacetabular osteotomy versus hip arthroscopy in a retrospective cohort of patients with borderline hip dysplasia. And then two, determine if the parameter correlated with these patients' post-operative patient-reported outcomes. So the parameter that we developed consists of two measurements that are variations of the aforementioned LCEA, the wall intersection with the psoas anterior, or WISA for short, and wall intersection with the psoas posterior, or WISP for short. So beginning with WISA, the anterior wall of the acetabulum is first identified, seen here on the inverted image. The LCEA methods can then be applied, shown in red, and then the new endpoint for the WISA is, instead of where the lateralmost aspect of the psoas is, to where that anterior wall intersects with the psoas, shown here in yellow. So in this example, the WISA is less than the lateral center edge angle. The same process applies for the WISP, where you begin by identifying the posterior wall, seen here. LCEA methods can then be applied, where the lateral endpoint will then change from the lateral psoas to the point where the posterior wall intersects with the psoas, which in this example is larger than the LCEA. So shown here are examples measurements that I made with the LCEA in red on both images. The WISA is in yellow on screen left, and the WISP is in yellow on screen right. The inclusion and exclusion criteria for our study are listed here. The final cohort consisted of 256 hips in 224 patients. 241 hips were treated with arthroscopy, and the remaining 15 underwent periacetabular osteotomy with a concomitant arthroscopy to address any intra-articular pathologies. Average age at the time of surgery was 30.4 years and was similar between the two cohorts. Radiographic measurements that we collected for each hip are shown in this table. In addition to the LCEA, WISA, and WISP, we also measured the anterior and posterior acetabular wall indices and the fear index, which are other proposed measurements to improve decision-making, but have reliability for identification of underlying instability and borderline dysplasia, which is lower than desired. And in our group, all measurements except for the posterior wall index were significantly lower in the periacetabular osteotomy cohort. Looking then at multivariate analyses, we tried to determine the effect of each radiographic measure on surgical management. Shown at the top are ROC curves for the LCEA and WISA, which were the best discriminators between the arthroscopy and PAO cohorts, with areas under the curve of 0.85 and 0.78 respectively. Then looking at the odds ratios, we found that a 1 degree increase in WISA on the preoperative radiograph decreased the odds of a patient's PAO indication by 17%. And similarly, a 1 degree increase in WISP on their preoperative radiographs decreased the odds that a patient underwent PAO by 10%, both of which were statistically significant changes. So based on the findings of this study, our novel WISA and WISP parameters were indeed predictive of surgical management, meaning PAO versus hip arthroscopy in patients with borderline hip dysplasia, and they may be useful in further delineating whether an arthroscopy or PAO is the preferred treatment for borderline hip dysplasia. Thank you again for the opportunity to share my research today. I'd like to acknowledge everyone that I worked with on this project, but particularly Dr. Andrea Spiker of the University of Wisconsin and Amy Armstrong for all of their help with everything and guidance. And thank you again. I'm happy to take any questions if we have time remaining.
That was an excellent presentation. Thank you so much, Regan. One question I have for you is, have your findings been incorporated radiographically, both from the radiologist perspective as well as the orthopods? Is that something that's starting to kind of pop up on reports or further discussed when it comes to preoperative management?
So as far as the current stage of our project, we're still in the process of writing this up. We have the manuscript draft. So we haven't incorporated it necessarily with the radiology colleagues yet. And we're also running some additional analyses to look at the patient-reported outcomes piece of this. I didn't quite have that data for this presentation today, but I'm sure that based on those results, it will inform this orthopedic surgeon team in terms of their decision-making in future patients with borderline dysplasia.
Excellent, thank you. Any other questions?
There's another question in the Q&A. Would you like me to read it?
Sure, thank you.
It says, have you looked to see if your hip measurements can be applied to MRI scans?
We have not, but I presume that they could be if you have a coronal image. It could be applied relatively similarly to an AP pelvis radiograph.
And then there's a follow-up that says, my question is similar. Measurements with by radiologist, MSK radiology, orthopedic surgery, and then they said intra versus intra-observer agreement, question mark.
Yeah, I apologize, I don't have the specific reliability numbers off the top of my head, but they all were in the strong reliability category. We did measure both inter and intra observer reliability for these measures. And then as far as measurements go, this is a single surgeon cohort, and the surgeon performs all of her measurements for her patients at the time of initial evaluation in her clinic, in addition to what is given to us by the radiologist. So she will perform these measurements, and if radiology also wanted to perform them, that could be done as well. But primarily it's the orthopedic surgeon making the measurements for these patients.
Thank you.
That's good. All right. Thank you, Regan. And our next presenter is Brent Berg. I'll hand it over to you. All right. Just make sure I have control of the slides. Perfect. So my name's Brent Berg. I'm a fourth-year medical student from the University of Minnesota. And my talk today is titled Juvenile Osteochondritis Dissecans Assessment Using Novel MRI Techniques. And before I get started, I just want to thank my research mentor, Dr. Yuta Ellerman, also from the University of Minnesota in the MSK Radiology Department. I have no disclosures to report. And before getting started, I just think it's helpful to talk a little bit about what JOCD was thought to be when it was first discovered. So it was first observed in the 1880s by Franz Koenig, a German surgeon. And as the name depicts, it was thought to be an inflammatory process of subchondral bone, which would then lead to fracture and formation of a loose body. As you can see, this X-ray over here on the right of the slide supports that interpretation. And as X-rays came into use soon after this was first observed, a lot of patients would present at this stage of the disease with ossification of the lesion, which kind of perpetuated that paradigm for a while. And this is because JOCD is asymptomatic early on in its course. And I'll get into that on the next slide, I believe. This talk's focused on JOCD of the knee, but it also occurs commonly in the elbow and talus in that order. So MRI is the flagship imaging modality for JOCD staging systems. Most of these systems are based on lesion stability, and a few basic criteria for instability of a JOCD lesion include high fluid signal at the lesion parent bone interface. As you can see here, I'm kind of tracing around the lesion. We have parent bone, and this would be your interface. Also, high fluid signal in parent bone subchondral cysts, and high fluid signal across the articular cartilage, indicating that there's articular cartilage damage, allowing for that fluid to penetrate into the interface. And the main issue with these staging systems is that while a lesion may be stable, that does not mean that it's necessarily healing. And up to nearly 50% of stable lesions don't heal conservatively and eventually require surgery.
So this slide is talking about the etiological theory of JOCD that the staging system and imaging protocol are based on. So as you can see here in this diagram from a paper by Chow et al., it's based on a theory that there's ischemia of epiphyseal cartilage during the development process, and that when the ossification front, in the case of the knee, the secondary ossification front reaches this ischemic area of cartilage, it's unable to ossify because it does not have a blood supply. So your secondary ossification front will progress alongside this necrotic area of cartilage, but not ossify it, leaving poor support for the overlying articular cartilage. And this can go one of two ways clinically. It can at times heal on its own and be asymptomatic, or only mildly symptomatic to the point where it doesn't rise to clinical attention, or it can present with a lot of pain, eventually joint instability or joint catching if a loose body's formed. And the theory is that this happens because of some instance of trauma or potentially cumulative trauma from activities like sports. And it most commonly affects 12 to 20-year-old patients. And down here on the bottom is a schematic from a paper by with my research mentor as the first author, just delineating that we have stages for the disease, stage 1 being an entirely cartilaginous lesion, stage 2 being a lesion that has start to have some rim mineralization, stage 3, a lesion that has begun to ossify once the blood supply has been able to penetrate and bring in osteoblasts and other factors necessary for this ossification. Stage 4, a fully ossified and bridged lesion. And at any point in this process, namely stages 2 and 3, you can have failure and formation of a loose body, which is what this type 2-3F is illustrating. And this whole staging system is based off the principle of using short echo time T2 star protocols, because this allows for delineation of the composition of the lesions. Typical MRI protocols for JOCD imaging use about 40 millisecond echo times, whereas this method uses a 4 millisecond echo time, allowing for contrast within the lesion. And as you can see here on this T2 fat saturated image, we have kind of a homogeneous hypointense lesion appearance versus this inverted T2 star. You can now see that within the lesion, you have some rim mineralization, some ossification on the left, and completely cartilaginous still on the right side of the lesion. This is just more images of the stages. So here we have a stage 1 lesion that's completely cartilaginous with the parent bone showing some subchondral sclerosis here. Stage 2 lesion, now depicting that rim mineralization. Stage 3, this lesion started to ossify in the center and is bridging across the interface with the parent bone. A stage 4 lesion that's fully ossified and bridged. And another image from a paper by Kajabi et al. Just showing a loose body in the joint space on the T2 star here on the left. So the take-home points for this talk are that JOCD lesions heal through a process of progressive ossification. This staging system is the first one based on the emerging etiology of JOCD as an ischemic insult that prevents ossification initially rather than inflammation that leads to a fracture across already ossified bone. And the hope is that tracking this ossification process and healing process will allow for intervention earlier on in patients that have stable lesions rather than waiting for instability to develop. And that basically, because surgery does have high success rates once it's used, and some patients can spend over a year in conservative management with little symptom improvement. There's also hopes to be able to use the T2 star images for quantification of the lesion healing process as it progresses from soft tissue to mineralization and ossification. And the long-term hope is obviously to have less inactivity, immobilization, and fewer long-term complications for patients. Here's just a write-up of a little bit more detailed of each stage, and these are my resources. Thank you for allowing me to speak today. And I'm happy to take any questions.
Yeah, great job. I have one quick question, and I think we have another one in the Q&A that I'll read out in a moment. But at your institution, at what intervals are people getting MRI on these patients to monitor healing? How frequently is MRI being obtained?
So this is like an emerging staging system, and it's really variable. That's kind of the point of the staging system, is that there's no consensus, even at our institution, of the like monitoring process and conservative management. And yeah, I couldn't give a specific time interval, I suppose, but that's kind of the
It's
hope of the
variable.
staging system, is to nail down how frequently these MRIs should be taken to assess whether this lesion is healing appropriately or it should progress to surgical management.
And then one other question from the Q&A, which you're welcome to pass on, and we can have someone else try and tackle this one unless you're more of an MR physicist Jedi than I am. So you're using short TE, but not ultra short TE. Do you think ultra short TE would give you better definition of the cortex?
I am not much of an MRI physicist.
You're in good company as far as that goes. I don't think I can answer that question either. So
yeah, I would be guessing.
That's fine. We'll let someone tackle that in the chat. One of our, I know we have some great MR people on board, and I'll turn it over to Barry to introduce our next speaker.
Thank you.
All right, great. Thank you so much, Brent. Excellent. And our next speaker is Lauren Fain.
Hi, sorry, how do I control? Okay, got it. Sorry. Hi, everyone. My name is Lauren Fain. I'm a fourth year at Case Western, and I'll be talking about integrating photography into musculoskeletal imaging interpretation procedures. I'd like to thank my mentors, Dr. Barger, Dr. Faraji, and Dr. Jiang, for their guidance and assistance with this project. We don't have any commercial interest to disclose. So visible light imaging, aka photography, is the kind of typical pictures we can take with the camera we think of. It is cheap, readily available, and easily integrated into traditional MSK imaging modalities such as CT, MRI, and ultrasound. We can integrate photography in many facets of MSK radiology, including recording patient position during acquisition, helping with interpretation through providing more clinical info, and documenting findings during procedures or how we did them. And photography can help us improve our patient outcomes through improving our diagnostic accuracy, confidence, as well as reducing bias. So photography can be helpful in confirming the patient position. For example, for lumbar x-rays, the oblique views can be a bit confusing. More often, the posterior oblique views are performed. When the anterior oblique views are performed, that can create some confusion. And although images are labeled, it could be labeled incorrectly, and it would be great to just have a way for the radiologist to confirm the position. So an example of how it can be confusing is that if we look at the topmost image, comparing the left side views, the left posterior oblique and left anterior oblique views, the left side is on opposite sides. And laterality is very important in radiology, and we want to be accurate in our reports, as well as not contribute to any mistakes in clinical management or surgical management. So what we can do is we can take pictures of the patient positions and associate them correctly with the radiographs. And this is a radiology tech who volunteered to get photographed in the right posterior oblique and left posterior oblique positions. Photography can be useful in documenting the site of concern, especially for ultrasound, since these target a small field of view. So that makes it hard for the localized lesion because it's meant to focus on the lesion and help us characterize it. So for this 60-year-old male with a palpable lump, it was more difficult for the tech to describe a location, and thus taking an image and annotating it to show where the lesion was helpful for the radiologist and describing the location in the report. So documentation photographically of superficial wounds is pretty helpful because they can be difficult to localize on traditional imaging modalities. For example, for the 63-year-old male, the ordering indication was toe wound, rela osteomyelitis. If you spend some time in the radiology reading rooms, it's not uncommon that the indication can be pretty general. Sometimes the notes aren't that much more helpful either. And so with the 10 toes in the foot, there's a lot of surface area where a ulcer can be and a lot of areas to look. And for this patient, before the photograph, for seeing that it was hard to see an ulcer. So the photograph showed us that it was in the lateral side of the third digit and between the third and fourth digits, and that helped us zoom in on where to focus on assessing for osteomyelitis. And that reduced our interpretation time and increased our confidence in our osteomyelitis diagnosis. Photography is useful for documenting what was done during procedures because other specialties may appreciate that information for their management. So for this patient with a lateral distal thigh mass, imaging was suspicious for a neoplasm, and the biopsy did come back as a spinal cell neoplasm. Documenting the trajectory is helpful for surgical planning. First of all, the future planned surgery may require a specific trajectory. Also, the trajectory may want to, the other people may want to resect the tract because especially if it's malignant, because the needle can seed the tract when you're retracting the needle. And lastly, documenting the site of access can be very helpful because once it heals, you might not see it well, and also we're using minimally invasive techniques. Documenting procedures is also useful when we're trying to localize a lesion for another group of providers. So for this patient with stump pain after a below-the-knee amputation, ultrasound was used to first confirm there was a neuroma and localize it. And so we drew a box around it, took a picture, and it was saved to the EMR. And so that's a good way, reliable way to save that information and provide it to the surgeons for their surgical target. And lastly, here's an example of photography being useful for documenting findings during procedure. So for this patient with a suspected septic knee, the arthrocentesis fluid was yellow and cloudy, and a photograph was taken and saved to the EMR, which is helpful when in the procedure report when we were describing our findings. Oftentimes the samples are given to the lab or some other people, and so you often don't take it with you back to the reading room when you're documenting your report. So in summary, photography has many promising applications in MSK radiology. Providing the extra clinical info, visual info through the photos can improve our diagnostic accuracy or confidence and reduce our interpretation time. It can be very helpful in documenting our procedural findings and what we did to communicate that to other providers that we're cooperating with. And photography is not without issues, notably security. Photographs are protected by HIPAA, and therefore we should be using secure devices to take the images and storing the images, and we should use a secure connection to transfer the images between those two locations. And more work can be done to demonstrate the systematic integration of photography to improve musculoskeletal radiology and our patients' outcomes. Thank you, and I'm happy to take any questions.
Lauren, that was great. Thank you so much. I think that's a really great idea. Just a quick comment in general, as radiologists, especially MSK radiologists, we often get a paucity of history, right? We get a study just as pain or it hurts and that's it. So I think these photos, if they're too busy to write a history or unable to do so, these photos would be super helpful in certain settings, particularly like the showing the osteomyelitis rule out cases and whatnot. I think that's extremely helpful, as are some of the sonography cases. So that's great. One question I have is, who is actually taking these photos at your institution?
We were partnering with like radiology techs and I think a wound clinic. And so they were helping with taking the photos.
Excellent.
Do you mind if I
Sorry.
elaborate? I was just gonna say, yeah, it's a lot of it's from the clinical providers too. I mean, when we're reading these studies, diabetic feet, I'm usually checking. We have a media folder in Epic, so we check there, and it's either from the podiatry office or the wound clinic, as Lauren was saying. So it's been a useful tool, I'd say. Great job, Lauren.
Thanks.
All right, and our next presenter is Ali Gassemi. Ali, I'm going to turn it over to you.
Hello, everyone. This is Ali Qasemi. I'm a postdoc research fellow at Johns Hopkins Radiology Department, Division of MSK, and I am proud to able to present this abstract to you. In this abstract, we tried to investigate whether or not MRI can predict the histologic grade of neurofibromatosis 1 related malignant nerve sheath tumors. And here's my email. Through the course of this presentation, we might skip some slides, so feel free to shoot me emails, and I'd be happy to answer any questions or discuss any matters with you afterwards. So, okay. Yeah, as a quick introduction, neurofibromatosis type 1 is a autosomal dominant mutation in NF1 gene, which is a tumor suppressor. And well, if you don't have a tumor suppressors, you get tumors. So the hallmark tumor in this disease is neurofibroma. And there are lots of different classifications for soft tissue sarcomas throughout the years, but the one that we are going to, our institution, Johns Hopkins, uses is the one that's introduced by Maitinen and colleagues in 2017. And you can see it's merely based on histologic findings, and it is a histologic finding, and we wanted to investigate whether or not we can guess or detect the grade based on MRI findings. And in malignant tissue, of the MPNSTs, the presence of necrosis is very decisive to classify the lesion low grade or high grade. So I'll explain these images later in the course. So yeah, the importance of this distinction is that the treatment approach is drastically different between pre-malignant or low-grade MPNSTs and high-grade MPNSTs. So we need to somehow be able to get prognosis for these patients in order to better planning for the treatment. So we hypothesize that whether or not MRI can distinguish between low-grade and high-grade MPNSTs, and spoiler alert, it can. So yeah. For this study, we used 41 scans of 40 neurofibromatosis 1 patients. One patient had 2 lesions, and we used the scans with the following sequences, and we used the scans that were done just before the biopsy, so we had a histologic proof of what that lesion is, as the gold standard. And this is the flow diagram of our study. It is color coded, so skip it. And again, we used that reference standard that I showed you in previous slides as our grading system. So yeah, our results in demographic data did not show any statistically significant difference between the low-grade and high-grade tumors, but in MRI, section of the data analysis, we found that, as you can see here, the bold ones, we have heterogeneity, perilesional edema, necrosis in T2 or stir images to be statistically significantly different between the two groups of lesions. And in DWI, we found that the median ADC minimum, and in contrast enhanced images, perilesional enhancement, and also the diameters, both largest and average, are statistically significant, showed statistically significant differences between the groups. And this is an example of the low-grade or pre-malignant images. This one stands for atypical neurofibromatosis of unknown biologic potential. So this sequence ADC shows the diffusion restriction. So as you can see here, we don't have any particular pretty dark spots, so it has some diffusion. And if we go to the next slides, the grade is higher here. So again, we don't see any pretty dark spots here, and in ADC here, you can see it's pretty homogeneous, and also in T2 fat set images. But in high-grade MPNST, as you can see in dynamic contrast enhanced images, we have early arterial enhancement, and also we have some pretty dark spots in fat saturated contrast enhanced images. So these represent necrosis, and also again in ADC images, you can see we have substantial diffusion restriction. So before we started to analyze the images for histology grading, we knew that MRI can distinguish between benign and malignant PNSTs, but we wanted to see if it can distinguish between, within malignant PNSTs. So that's why we try to do this analysis. And to our knowledge, there are only 3 studies that discuss atypical neurofibromas or the neurofibromas of unknown biologic potential. I'm going to skip these slides. And also, well, again, in our study, there were some limitations. But to conclude, we found that intralesional necrosis, perilesional enhancement edema, and lower ADC mean, as well as some other features, can be used to distinguish between the high-grade and low-grade MPNSTs. So I'm happy to take any questions, and thank you all.
Ali, thank you. We probably have time for one question, and we can keep the questions going in the Q&A. So please take a look at that Q&A, and you can answer some questions in there. But I'll take advantage of my role as moderator to steal the one question, because I'm very curious about this. So it seemed like there were multiple features that were predictive of high-grade histology, but no one feature was perfect. So I noticed there was overlap between the two groups and the ADC values, for instance. Do you think that maybe a scoring system that incorporated multiple of the features, the perilesional edema, the ADC values, things like that, would be helpful to assess those things in aggregate to predict lower grade histology and higher grade histology based on the MR features?
Of course. The thing is, we need to, as the systems, RAT systems for bone lesions, we need to, which are, there are at least 5 of them. we need to standardize, first of all, reporting these lesions and the surveillance. But I agree with you that if we can incorporate some of the lesions together, some of the MRI features together, and then calculate the specificity and sensitivity of them in the distinguishing between high grade and low grade, that's also a good idea and might be the topic of our next research.
Excellent. All right. Thank you very much.
Thank you.
All right, thank you so much for that. And for our next presenter, we have Jeffrey Gerardo.
Okay, beautiful. Hi, everyone. I'm Jeff Gerardo. I'm a fourth-year medical student at Case Western, and I'm going to be covering some of the clinical and imaging manifestations of seronegative spondyloarthropathies. I want to give a shout out to Orlando Martinez, one of my classmates, for helping me out with this, as well as Dr. Faraji for his mentorship. I don't have any financial disclosures to report. So seronegative spondyloarthropathies are a group of inflammatory diseases, including things like ankylosing spondylitis, psoriatic arthritis, reactive arthritis, and inflammatory bowel disease. They share a group of common clinical and imaging manifestations, commonly presenting between the second and fourth decades of life. Clinically, they often present with chronic inflammatory back pain that will improve with exercise. Patients often report having morning stiffness that then improves as the day progresses. Also, they report some peripheral arthritis and then extra-articular manifestations like rash, anterior uveitis, and bowel symptoms, some of which I'll cover towards the end of the presentation. And as far as imaging goes, there's kind of two general buckets that imaging manifestations will go into: some of the more acute inflammatory lesions, and then some more chronic structural changes that can be seen as well. MRI is essential for visualization of some of these more acute inflammatory lesions. Common sequences include T1 and fat suppressed T2. And the focus of my presentation is going to be on sacroiliitis affecting the SI joints and hip joints as well, although other skeletal areas such as the spine are very commonly affected. So starting off with one of the common inflammatory lesions that can be seen is marrow edema. So here we have a T2 fat saturated sequence depicting some bilateral marrow edema of the iliac bones. So commonly, towards the beginning of a patient presenting with one of these spondyloarthropathies, they'll get inflammatory infiltrate as cytokines are released, causing edema in the bone marrow around the joints that are affected. So here we see that around the SI joints, right, a little bit greater than left there. And as that edema and fluid accumulate, you get increased T2 signal here, showing up as that kind of bright signal intensity due to the inflammatory infiltration. Another common inflammatory lesion that's seen in spondyloarthropathies, non-specific but very common, is capsulitis, which is inflammation and fluid accumulation within and around the joint capsule. So here we have a very classic image of a T2 fat saturated sequence highlighting some small joint effusion and capsulitis seen in the right SI joint there, right over here. With some adjacent soft tissue edema seen as that bright T2 signal in a patient that had ulcerative colitis. So it's important, when you're looking at pelvic scans for patients that have like bowel manifestations, or for patients that are endorsing back, spine, or buttock pain, to kind of look for things like capsulitis and sacroiliitis as well. Here's another example of capsulitis, this time on the left. We have a T2 fat saturated sequence here, highlighting a joint effusion with adjacent soft tissue edema here. So you kind of see the fluid accumulating around that joint capsule, and then also kind of going back to earlier, we discussed the bone marrow edema, and you kind of see that in the left iliac bone right here as well. Another common inflammatory lesion is enthesitis, or inflammation of the entheses, which are the tendinous and ligamentous attachments. So here we have a T2 fat saturated image showing some bilateral greater trochanter enthesitis, seen as that brighter T2 signal at the greater trochanters, and then a little bit on the right lesser trochanter as well. Enthesitis is a very, very common manifestation of seronegative spondyloarthropathies, and can kind of clue you into the diagnosis if the patient presents with some of those common clinical history that we had discussed previously. Additionally, here's another classic image of enthesitis, but this time seen at the bilateral ischial tuberosities. Another kind of important site to look for, because there's a lot of tendinous and ligamentous attachments there. And then kind of as you move past that acute phase, you kind of get into more chronic lesions and structural damage. One of the first ones seen is bony erosions. As the inflammation kind of becomes chronic, the bone itself will start to be eroded. So here we have an axial CT that demonstrates some bony erosions in the right SI joint. You see some of that joint space narrowing and widening at various intervals, and a kind of disruption of the natural outer cortex as well. And then with bony erosion, it's often accompanied by fatty backfill, which is as the bone is eroded, you kind of get fat that will then fill in as the body attempts to heal the inflammatory area. This is best seen on a T1 sequence. So here we see kind of some bilateral fatty backfill of the bilateral SI joints, which is kind of a clue that you're looking at more long-standing inflammation, and likely the patient has been having symptoms for quite some time, generally seen in more chronic cases of spondyloarthropathies. Also often accompanying fatty backfill is fat metaplasia, which is kind of an infiltration of the bone marrow with tissue that exhibits more fatty signal. So because this image is fat saturated, you're going to see that more dark signal indicating the fat metaplasia around the right SI joint there. And this is a pretty late stage change of spondyloarthropathies, indicating again that long-standing inflammation. Generally, there's underlying joint erosion, and at this point, you're kind of progressing towards ankylosis, which is kind of the end stage hallmark of seronegative spondyloarthropathies. So here we have kind of a T1 image showing complete ankylosis of the left and right SI joints, or complete fusion in a patient that had ankylosing spondylitis. So generally, these patients will begin with some, mild sacroiliitis that will then progress. They'll get erosions, fatty backfill, and eventually the joint itself will kind of fuse together. And this is kind of the final stage change, often seen with patients with ankylosing spondylitis. And then some common radiographic signs wanted to include that are seen. These are both seen commonly in patients with ankylosing spondylitis specifically. On the left here, we see the dagger sign, which is ossification of the supraspinous and interspinous ligaments, secondary to chronic enthesitis. They get ossification of those ligaments, and then that will appear as like kind of a downward looking dagger. And then they can also see syndesmophyte formation, which is ossification of the annulus fibrosus and spinal ligaments kind of over the vertebral discs, seen right here as they kind of course over the discs in that area. And then there are some common extra-articular manifestations, like I mentioned earlier, uveitis, psoriasis, rash, etc. So here we have a CT showing some rectal wall thickening and fatty infiltration of the submucosa, suggestive of IBD. So if you're getting pelvic imaging of a patient that is endorsing back, lower back or spinal pain, it's kind of important to also look for signs of IBD as well, as they might, have some underlying issue in that area. So in conclusion, common acute inflammatory changes seen can be marrow edema, capsulitis, or enthesitis, and then there's common chronic and structural changes like bone erosions, fatty backfill, fat metaplasia, ankylosis, and syndesmophytes as well. These should aid in accurate diagnosis and are crucial for effective management. And those are my references. Thank you.
Excellent. Thank you so much, Jeff. Really nice review there of the seronegative spondyloarthropathies. Any questions, comments from the gallery?
So there is a chat and Q&A. It says, over the years, there has been a lot of debate about the best MR sequence for erosions, and a strong argument has been made for T2 star fast echo FE imaging. Do you have an opinion?
Kind of in my review, I found that comparing T1 and T2 fat saturated specifically were the easiest for me to see some of those more acute inflammatory lesions. So that would be my personal preference, but I'm our expert by any stretch of the imagination. So I would probably leave that up to the prerogative of the individual reader for sure.
All right, thank you so much, Jeff. Again, excellent work.
Sounds good. All right, moving right along. We have Veer. Do you want to kick it off with your presentation?
Yep. Okay, so I'll be doing a presentation today on carpal dislocations, comparing pathologic and not normal radiographs of the wrist. Okay. No disclosures to report. So just going over quickly the learning objectives, we're going to go and discuss lunate and perilunate dislocations, reviewing anatomy, go over some radiographic signs, and discuss this based off of, try to look at a case to help characterize these findings, and then talk about the importance of identifying these injuries to aid with limiting complications of the disease. So starting with a case, there's this is a 36-year-old female who presented with right wrist pain and paresthesias after a motor vehicle accident. Physical exam was significant for right wrist swelling with pain. And here we have the imaging for this patient. So keeping in mind, taking a look at the carpal bones of the wrist, we'll go on to see the actual impression and make a differential here. So the impression we got was that there's lunate dislocation, which and evidence of volar intercalated instability, which suggests rupture of the lunotriquetral ligament. We'll go into these terms further and characterize and explain them. But first, let's talk about the other option in the differential here. There was, as the diagnosis here was lunate dislocation, but we also have to consider perilunate dislocations and other central carpal dislocations. So perilunate and lunate dislocations both can occur from Fuchs injuries, where the hand is extended. These dislocations occur due to failure of ligamentous structures, which can lead to instability. And we need to evaluate these injuries, as if we miss it, it can lead to nerve entrapment or chronic pain. So we're going to first take a look at the normal appearance of an X-ray. On the left, we can see that there's no displacement of any carpal bones. The highlighted lunate bone is still in place. And you can see that the carpal arches, the arcs of Galula, are still intact here. On the lateral X-ray, we can see that there's no evidence of any subluxation or of the carpal bones. They're all still intact here as well. So now we'll go into characterizing the lunate versus perilunate dislocation. So this image is just highlighting the image we just reviewed, or images we reviewed earlier. On the left, we can see something called the spilled teacup sign, where you can see that the lunate is tilted in a volar direction towards the palm. And on the right, you can see that the lunate is overlying the other carpal bones. When this occurs, the lunate can even look different in shape, which is where the name, the piece of pie sign comes from. Basically, there you'll just see that the lunate is overlying other carpal bones and may even take on a triangle appearance at times. Otherwise, the lunate dislocations, when you compare these to perilunate, it's important to understand that lunates have higher degrees of instability, so it's more likely to cause median nerve compression. Now we're going to take a look at some perilunate dislocations. When you compare to lunate dislocations, this radiograph shows that there's dislocations of the carpal bones aside from the lunate. You can see that the carpal arches are no longer symmetric. And on the lateral X-ray, you don't see any, you don't see that spilled teacup sign. You don't see any tilting of the lunate itself. The next imaging here. So the other thing we talked about was the volar intercalated instability. You mentioned that in the impression. So this type of instability is very suggestive of a lunate dislocation. We can calculate this by calculating something called the scapholunate angle, which is measured by drawing a line that goes through the lunate and a line that goes through the margin of the scaphoid. When you see that angle is reduced, that can be suggestive of a lunate dislocation. So in conclusion, just talking over again, in conclusion, when you look at both perilunate and lunate dislocations, these are both important complications of Fuchs injuries, fallen outstretched hands, which we need to identify properly to aid in treatment and identify the extent of injury. If you can treat it swiftly, you can reduce long-term complications. All right. And here are my references, and that's it.
Great presentation there, Veer. Good job. Does anyone have any questions? Anything from the chat? Okay, maybe I'll have a quick question. This is just anatomy. If you can go back to your lateral slide, do you understand why a lunate dislocation would be more likely to cause median nerve injury?
Just because of the more anterior, like the location being more on the anterior aspect of the wrist.
Yeah, that's where your median nerve kind of lies. It's volar. So yeah, perfect. Good job. All right. Any questions from anyone else? Okay. All right. So moving right along, we'll have Ashima present her her presentation.
Hi everyone, my name is Ashima Kundu and I'm a second-year medical student at Loyola's Church School of Medicine in Chicago. And today, oh, do I not have mouse control? Okay, I think I have it now. Today I'll be presenting evaluating the predictive value of a novel MRI CT-based scoring system for vertebral discitis osteomyelitis biopsy culture outcomes. And I do not have any disclosures. So to start off with some background about vertebral discitis osteomyelitis or VDO, this is a serious and potentially life-threatening disease which affects the vertebral bodies and the intervertebral discs. And in more advanced stages, it can also affect the paraspinal and epidural spaces. And the clinical presentation includes fever and back pain and can even progress to spinal instability and neurological deficits. And it has been noted that there is an increasing incidence of VDO in the US due to a variety of factors, including increased rate of spinal interventions, increased life expectancy of patients with chronic and immunosuppressive drug use, and increased prevalence of intravenous drug use. And so the two most common imaging modalities used to diagnose VDO include CT and MRI is a preferred imaging method. On CT, we look for the vacuum sign in disc space, and if we see that, then it points towards degenerative disc disease. On the other hand, if we see disruptive end plate and paraspinal inflammatory changes, then it's pointing towards infection. And so in this study, we wanted to see how imaging led to the selection of patients that were going to have image-guided biopsy, and then in turn, how the cultures that we got from the biopsy led to a clinical impact. And in particular, we were very curious to see how this led to a change in antibiotics, if any. And the patients that we selected for this study included those who had CT-guided spine biopsies performed at Loyola from 2013 to 2022, and patients had to be 18 years or older, and they had to have imaging and clinical signs pointing towards having VDO. People that we excluded from this study included those who had biopsies for suspected malignancies, those who had no prior imaging available, those who had repeat biopsies, and those who had procedures that were technically unsuccessful. And so after filtering through all this criteria, we had a total of 70 patients that were included in the study. And the data we collected included a variety of variables, including demographic variables such as gender and age at the time of the procedure, and others such as biopsy cultures, CT and MRI images, biopsy level, lab values, blood cultures, and all the oral and intravenous antibiotics that were administered during the hospital stay and up to 1 month after. And there was an MRI-based scoring system that was developed for this study. And so I'm going to walk through this. A score of 1 indicates that there is positive hyperintense T2 stir signal in the disc, and that's shown by this blue cross right over here in this image. And a score of 2 includes everything that a score of 1 has, in addition to marrow edema and vertebral end plates, and that can be seen with those yellow asterisks here. And finally, a score of 3 includes everything in a score of 2, in addition to soft tissue edema and/or an abscess. And so when we looked at our data, we noted that of all the patients that had gotten image-guided biopsies that we included, 40% of them ended up having positive cultures. And then of that 40%, we noted that 75% of them saw a change in their clinical management. And when we were looking at the CT scoring system and culture results, we noted how out of the patients that had negative vacuum sign, 89% of them had positive culture results, whereas those who had positive vacuum sign only had 11% positive culture results. And the sensitivity and specificity for these results were 88.9 and 48.9% respectively. Similarly, in the MRI scoring system, we can see that for the category with no soft tissue involvement, with the score less than 3, only 15% of the patients had positive culture results, whereas those with soft tissue involvement had, we could see that 85% of them had positive culture results. And for the ROC curve for combined probability of MRI and CT scoring system, we saw a positive coefficient for the MRI scoring system with an associated p-value of 0.005, and the area under the curve was 0.75, which indicated that the model had good predictability. So some of the key points from our study included that a majority of patients undergo spine biopsy without any clinical impact. And like going back to the slide, we saw that 40% of the patients didn't even, only 40% of the patients had a positive culture. And then of that 40%, 75% had they had a clinical impact in their course of treatment. And then we can see that positive vacuum sign on CT is predictive of negative culture results, and similarly, no soft tissue involvement on MRI is predictive of negative culture results. And finally, it's important to bear in mind that imaging results should be used judiciously to select patients for biopsy. Some limitations in this study included the fact that due to the retrospective design, the nature of the study is susceptible to selection bias and confounding factors. Additionally, our data was collected from a single institution and had a limited sample size, so future studies would have to include a larger sample size to study this topic further. And finally, combining the predicted probability of MRI and CT scoring systems could lead to discordant results, and so it's imperative to consider that these results in light of the particular clinical settings in which they may have been applied, as well as any possible consequences for patient care. And all in all, we would recommend using this MRI scoring system in order to better select patients for image-guided biopsy. And that concludes my presentation. Thank you so much. Do you all have any questions?
Great job there, Ashma. Let me check the chat and see if anyone has any questions here. Okay. So just and feel free to pass this question if you would like, but I think in radiology in the past it's been pretty there's been this this discussion about having a vacuum phenomenon and that excluding any kind of osteomyelitis. Like if you see that on a CT, you can say flat out no, like this patient doesn't have any osteomyelitis. Again, based off your results, would you use that as a factor to completely exclude discitis osteomyelitis?
I think that would require maybe some discussion with also infectious disease doctors, because we did see that there was that 11% that still had positive culture results. So I think it depends on like what angle you're looking at it from. I think if you're looking at it from like a kind of like the kind of economic impact of doing these procedures on a lot of patients that might not have positive cultures, then maybe it might lead to a different answer. So I think that like discussion with different physicians would be necessary to kind of come to an answer for that.
Yeah, I completely agree. And there was a paper, I think it was Dr. Chang and her colleagues, with where they did describe that even with the vacuum phenomenon, you can have discitis, presence, have positive cultures for discitis osteomyelitis. But I agree, you clearly show a trend with if you have a soft tissue phlegmon associated with the discitis osteomyelitis that increases the risk, and having that vacuum phenomenon decreases it slightly. But yeah, great job with that presentation. I think we have a question in the chat. Dr. Anderson says, were the biopsies performed by a single radiologist? Did you delineate the results further down by individual radiologist?
So that's something that we need to look into more. But one thing that we did notice that when we were doing the scoring system, there were 4 instances in which there were 2 radiologists that were scoring the biopsies or the CTs, and they had noted that there were some discrepancies. But out of the 70 patients, it was just for 4. So we would need to look into that further.
Thank you, Ashima.
Thanks. All right, thanks, Ashma. We'll moving right along. We'll have Thomas. Thomas.
Okay, hi. Thomas, I'm MS3 at Downstate. I'd like to thank my all my mentors that helped with this project and give me the opportunity to present here. None of this would have been possible without them. So starting off, my project was looking at the accuracy of MR imaging for the diagnosis of incidental lower extremity DVT. How do I? Okay, oops. I have no financial disclosures. And DVTs are important to diagnose because they have the potential to propagate towards the lungs and form pulmonary emboli. So the term venous thromboembolism refers to cases of DVTs and PEs. And although only estimates of yearly DVT incidents exist, over 1.2 million people in the US were diagnosed with venous thromboembolism in 2016, 60% of those being DVTs, and the 1-year mortality of a PE is at 19.6%, so that's not low. Risk factors for thrombosis include venous stasis, endothelial damage, and hypercoagulability, all of which occur during lower extremity musculoskeletal injuries. And that increases the risk due to the subsequent immobilization and inflammation. And complete duplex ultrasound is the current standard imaging test for suspected DVT, but symptoms of musculoskeletal injuries and DVTs often overlap. So it would be very beneficial if MRI is done to evaluate musculoskeletal injuries can incidentally detect these DVTs before an ultrasound is done. And then the supporting features of DVT on MRI are venous enlargement, perivascular edema, and intravascular signal heterogeneity or decreased intravascular T2 signal. Here are some examples of those features. So on the left, so these are 2 axial MR images of a patient's calf that was positive for DVT. On the left, it illustrates venous enlargement of the posterior tibial and peroneal veins. On the right is an inversion recovery sequence that highlights the perivascular edema that you can see highlighted by the blue arrows. So the objectives of our project were to confirm that the MRI findings and features associated with lower extremity DVT on studies initially obtained for other musculoskeletal indications. And we want to determine the accuracy of MRI for DVT with contemporaneous ultrasound as the reference standard and determine inter-rater agreement between 2 radiologists when they suspect DVT on MRI. So this was a retrospective study for MRI cases found on a radiology report database. These were our search terms. Cases without follow-up ultrasound within 1 week of the MRI were excluded. MR venography was excluded. An additional 2 cases were excluded due to inadequate ultrasound evaluation. I'll talk more about that in the limitations section. And this was our resulting sample size of 42 and the distribution of lower extremity locations. The MRIs were then read by two experienced musculoskeletal radiologists that were unaware of the ultrasound results to determine whether the three key features of venous enlargement, perivascular edema, and intravascular signal heterogeneity were present, but also whether fluid levels were absent and whether DVT was suspected. Sensitivity, specificity, positive and negative predictive values were our main measurements, along with inter-rater agreement. And here's a visual of the fluid levels. You can see the clear horizontal fluid interface shown next to the red arrows. For our results, tables 1 and 2 correspond to each radiologist. The three key features were all sensitive for DVT, but not as specific. Negative predictive value was for absent fluid levels was 1 for both radiologists. DVT interpretations for 10 of the MRIs that we had for the calf matched exactly those of their contemporary ultrasounds. MRI also showed high suspicion for DVT in 2 of the ultrasounds that were negative and excluded from our overall analysis, but I wanted to mention them here since they are examples of MRI that picked up DVTs in the calf, whereas the ultrasound did not. And there was substantial agreement between the two raters. So our results show the strong association of the three key features with DVT on MRI, which is consistent with prior literature. And because the absence of fluid levels are highly sensitive with high negative predictive value, the presence of fluid levels can be a factor taken into account when trying to rule out DVT. Some limitations of our study is also possible selection bias because it was a retrospective study. We also had a small sample size. There was an unequal distribution of cases of different lower extremity segments, and that prevented us from stratifying our cases to different segments when doing our analysis. And finally, using ultrasound itself as the standard, ultrasound itself is an imperfect test. Compression ultrasound of the calf only has a sensitivity of 56.8%. It's also operator and patient dependent. And one of the cases is an example of this that was excluded because the identified vessel of interest on MRI was missed during ultrasound evaluation. Another case with MRI suspicious for DVT had a negative ultrasound done at another institution, but it was unclear by their report whether the suspected intramuscular vessel was imaged. And then the other excluded case, the ultrasound had poor penetration and the vessel couldn't be visualized. And I have images for that example coming up. But first I want to look at what a normal ultrasound of the calf would look like and an MRI. So images A and B are without and with compression. The present vessel should be apparent before compression, and notice that the size of the normal posterior tibial vessels by the blue arrows compared to the venous enlargement showed earlier in this presentation. And then this is the excluded case previously mentioned. The patient has significant edema, fat infiltration of the calf, along with features highly suspicious for DVT of the peroneal and soleus veins, but none of these veins were visualized on ultrasound even without and with compression as shown on the right. So we concluded that MRI obtained for musculoskeletal indications can detect DVTs, but we should continue to confirm by lower extremity ultrasound as in current standard practice. However, in cases where calf ultrasound results may be equivocal for DVT, MRI has the potential to function as a confirmatory test and detect them in cases where ultrasound did not. Thank you.
Fantastic. Great job, Thomas. Anyone have any questions? So Thomas, maybe, okay. Dr. Anderson has one, Dr. Weiss. All right, great.
I wanted to know, would you guys consider maybe including like a price analysis? Because MRI following up ultrasound, one is obviously very cheap and easy to do, and one is a lot more difficult in terms of access and expense.
We haven't actually considered that, but in terms of what we're targeting now is initial MRIs for other musculoskeletal injuries that have already been done. And we're hoping that we can identify the DVTs on those without having to do a further ultrasound or catch it earlier.
I guess one of the questions I have are, first of all, now I need to know to look for the fluid levels. I guess the main situation I find myself in daily practice is reading a near calf MRI. I kind of see the things that you've talked about, like the enlarged vein, the perivascular edema, the signal changes in what in the vein, really, and it's mostly in kind of like that intramuscular branch in, say, the gastrocnemius. And I kind of question or raise suspicion for, venous thrombosis, and the patient gets, their lower extremity ultrasound, but the sonographer doesn't look necessarily at the calf veins. How do your clinicians handle that in terms of how does that affect management? Do they treat it like a DVT? Do they believe that the MRI is a truly diagnostic study in that setting? Or do they say, well, the ultrasound was negative and not anticoagulate the patient?
I'm not entirely sure on how it's handled based on the cases that we've already had. But there was a specific case where it was all the features. So each of the features in itself aren't indicative of a DVT, like the perivascular edema, the venous enlargement, and the changes in the signal. But together, there's a pretty high suspicion. And in one of our cases where the ultrasound had actually missed the vein of interest, the addendum for the report for the MRI was actually corrected because the ultrasound was read as negative, but there was definitely a much higher suspicion on the MRI. So in terms of how frequently the MRI takes precedence over the ultrasound, I'm not entirely sure, but it did happen in that case.
Do you
Like that.
suspect this happens with patients who are, of a different larger body habitus where ultrasound is not as easy to look at certain structures?
Um, that's possible, especially with the case. Especially if the patient has like associated edema of the calf, which was one of the cases that we had. If they have excess fatty tissue, that could affect the penetrance.
Okay, perfect.
All right. Thank you so much. So I guess up next we have Justin Partovi.
Hello. Is my mic working okay?
Loud and clear.
I don't know what happened to the title. And also, I control.
Click in there, you'll
There
get
you
it.
go. Okay. There you go. Okay, thank you. So hello, my name is Justin Partovi. I'm a fourth-year medical student at Western University of Health Sciences in Pomona, California. I join you in company with my good friend, Dr. Amjad Murdos of Cooper University Hospital in Camden, New Jersey. And this is our lecture, Little Ankles, Big Injuries. This is going to be a full review of pediatric ankle and foot sports injuries. I have no conflicts of interest. Oh, that slide didn't make it. I do not have any conflicts of interest. So this is a brief outline. We're going to have 3 cases, the triplane fracture to the Sever's disease, and then a couple classifications of ankle injury to leave you guys off with. So why is this important? Well, as you guys know, children have unique anatomy in the presence of the growth plate, and that requires special consideration for education. Their treatment options differ from adults, and because of that, the advice to referring clinicians will also differ. There's also a high prevalence of injury. There's 3.5 million children injured annually, and almost half of them are of ankles alone. So this is definitely a high yield concept that you guys will definitely encounter a lot in your career as a radiologist. And there are long-term consequences. There, without proper treatment, there could be growth disturbances, angular disturbances, dermatologic and neurologic disturbances as well, among others. So first and foremost, we have the triplane fracture. This is a supination injury. This is going to be a fracture, in this case, of the distal tibia, involving 3 different planes of bone, hence the namesake of the injury. We have here on the top image, the lateral, we see the transverse fracture across the physial plate, also noted on the bottom AP view here. We have a coronal fracture through the metaphysis, noted on the lateral, and then we have a sagittal fracture through the epiphysis. So this is fairly common. 10% of distal tibial fractures are triplane fractures in adolescents. And specifically among those with closing growth plates, this is the most common because, as you can see on the bottom image, the medial aspect of the growth plate had likely already fused, leaving the lateral part of the growth plate vulnerable to injury. So when you're assessing for triplane fractures, you want to assess for the severity by looking for displacement, fragmentation, and extension into the joint space. So our next case is osteochondritis dissecans. We should all be experts on this by now. Thank you to Brent. This is aseptic necrosis of hypovascular subcortical bone, usually due to either a direct trauma or chronic microtrauma. As we know, this is most common in the femoral condyle, but also possible in the talar dome. If we turn our attention to the left here, we could see this lucency in the talar dome with rim sclerosis. And we not noted here, but possibly we could see fragmentation in the joint space. We would expect to see like a density here. So this is often asymptomatic until adulthood. And the reason this is important to understand radiographically is because early diagnosis is important to reduce long-term complications, such as persistent pain and degenerative joint disease. So when evaluating for osteochondritis dissecans, you want to look for differentiated from a normal variant ossification of the distal femur. So that here you would expect possibly irregular sclerosis of the epiphysis here in the distal tibia, or the distal, this should say tibia, the distal tibia, or osteomyelitis and stress fractures, which you would not expect to see the rib sclerosis. Moving on to our last case, we have Sever's disease, also known as calcaneal apophysitis. This is inflammation of the calcaneal apophysis due to repetitive microtrauma, similar mechanism as the last one. This is also fairly common with 4 per 1,000 adolescents suffering from it. So this is actually usually a clinical diagnosis, not requiring any scan, where you would expect to see posterior heel pain with activity in an adolescent. Nonetheless, the radiographic features, as you can see on the top right on the X-ray here, we could see that compared to the normal, there's irregular sclerosis of the apophysis with irregular density and associated soft tissue swelling. And we could see in the normal that the apophysis here is more in line with the rest of the calcaneus. So it's one interesting note about the Sever's disease is that 5% of children have an additional abnormal finding requiring more aggressive management. So this is why you want to take a radiographic look at Sever's disease when you're suspecting it. You could evaluate for stress fractures or unicameral cysts. So we're going to go over a couple of classifications of ankle injury, notably the Lauk-Hansen classification. This one looks more directly at the mechanism of trauma and the resulting pattern of bony and ligamentous injury. So if we turn attention to the left in the figure on the left side of the figure, we could see that the nomenclature consists of 2 components that both have to do with the position of the foot and the time of injury. First word being pronation and supination. The next couple words being external rotation or adduction or abduction. I'm not going to bog you guys down on the details of the actual categorization of it because it's very involved, but basically the more anatomy involved, the worse the grade of injury, and supination injuries tend to affect lateral structures, and pronation injuries tend to affect medial structures. And we also have the Weber classification of ankle injury. This one actually focuses more on this overall stability of the ankle and the integrity of the fibula. You look at the involvement of the distal tibiofibular syndesmosis, the syndesmosis being the ligamentous structures that overall keep the ankle stable. That includes the interosseous membrane, the AITFL, PITFL, and the transverse tibiofibular ligament. A as infrasyndesmotic, which preserves ankle stability and usually does not require surgical management, whereas C does involve ankle stability and usually does require surgical management. So this is just a case that describes one of the injuries. So this is pronation, external rotation, grade 4 on the Lauk-Hansen, and then Weber grade C on the Weber classification. If we could tell just by the nomenclature, this person probably requires surgery, but nonetheless, we could evaluate some of the radiographic features. So we could see that this is a trimalleolar fracture because the medial malleolus identified here on the left image, the lateral malleolus, the proximal lateral malleolus, or the fibular shaft, superior to the syndesmosis noted here, and then the posterior malleolus fracture indicated here. Those are all described in the PER grade 4, and the Weber grade C is proximal to the syndesmosis. So just to wrap it up, big picture, pediatric anatomy and pathology are unique. So special attention is required for educating aspiring radiologists to make better patient outcomes. Accurate and early diagnosis guide proper treatment to vulnerable population and reduce complications. And then different classifications exist, and they're important to streamline communication among colleagues and to guide treatment algorithms. Thank you for your attention.
All right, thank you. That was a really great overview. I always find the diagnosis of the Seaver disease on the X-ray a bit challenging, but so we did have one question, which I thought was an interesting question in terms of thinking about kind of the mechanism classifications behind ankle injuries. Is there a difference in the types of injuries that are produced between pediatric patients and adult patients with the same, I guess, the same type of injury force, meaning that, the Lauk-Hansen classification apply similarly to both pediatric and adult patients, do you know?
That's actually an excellent question. I didn't specifically look into that in particular, but I imagine since the growth plates are not necessarily involved in grading and classifying using the Lauk-Hansen, for example, I imagine that you could use that to describe the injury. But I guess when you're communicating it to the orthopod or whoever's involved in managing care of that patient, it might differ in the overall treatment of the patient compared to a pediatric patient, if that makes sense.
No, it does. Yeah, I find it challenging too. I kind of always have to work backwards, where I just kind of look at kind of the injury patterns that I'm seeing and kind of deduce what the injury mechanism was, because we never really get that information, in the trauma setting. But yeah, I don't know either if it is, if there's a difference between, so we don't really have a pediatric population in our institution. So I think that's an excellent question. Any other questions or comments? If not, next we have Carol Sanchez-Santana.
Hi everyone, my name is Carol. I'm a third-year medical student at San Juan Bautista School of Medicine in Puerto Rico, and I did a review paper with one of my mentors from Yale School of Medicine, Dr. Babina Gusangi, and it's titled A Comprehensive Imaging Review for the Management of Scapulothoracic Dissociation. And here are various of the objectives. So it's to review the epidemiology and etiology of this injury, as well as commonly associated injuries. I'll be demonstrating some of the key imaging features for its evaluation. I'll also be discussing additional thoracic injuries that are involved when patients have scapulothoracic dissociation, and also a classification system they use to determine the severity and management of scapulothoracic dissociation. This is just stating that I do not have anything to disclose. So just a brief background. The scapulothoracic dissociation is defined as a complete loss of the scapulothoracic articulation with a lateral displacement of the scapula that oftentimes in the literature, they mention that it resembles a closed forequarter amputation. This is primarily caused by motorcycle accidents, but can also be due to other high energy trauma, such as vehicle crashes or very severe falls. And this can also lead to other severe upper extremity fractures. The mortality rate has been rising to 11% right now. And some of the manifestations that we can see with other types of injury as well can be swelling, bruising, and also in severe cases, you can see a flail upper extremity that has reduced or absent pulses. The diagnosis, there's mainly like case reports right now and more review papers on identifying this injury, but it is still often missed due to polytrauma. So patients will have other types of fractures as well as the scapulothoracic dissociation. So it requires a thorough examination. And the initial imaging is done with a chest X-ray and then followed with a more advanced imaging with a CT or MRI based on associated injuries. There are trauma protocols in place to manage this injury, as well as the classification system to assess the injury severity and functional outcomes. So to start off with, one of the consequences that can happen with scapulothoracic dissociation injury, as you can see here with the green arrow, is an aneurysm. So here's like the clavicle and then an aneurysm, especially with like the subclavian artery, it can occur. These is the imaging findings for scapulothoracic dissociation injuries. So figure 1 shows the plain chest X-ray. That's the first line of investigation. As you can see here, as you can see right here, there's a significant lateral displacement here of the clavicle, and right here another fracture of the clavicle, but this one's like a lot more displaced. And here is another image of the same one, 3D reconstructed CT of the scapulothoracic dissociation injury. Here you can see also the laterally displaced, and then as well as the clavicle fracture. These are the additional thoracic injuries that you can see with scapulothoracic dissociation injuries. In figure 3 here, you can see a pulmonary contusion on the right chest wall. You can see a hematoma and a right pulmonary contusion. In figure 4, you can see a pneumomediastinum with a small left pneumothorax. And then in figure 5, you can see this hemothorax, moderate hemothorax on the left side. Here kind of showcases more of a pseudo aneurysm of the right axillary artery. This image on the left, you can see this is an axial view of the CT scan that demonstrates a focal outpouching from the right axillary artery. And then on the right side, this is a sagittal view of the CT scan, also showing the focal outpouching from the right axillary artery. That's usually seen with a pseudo aneurysm. One of the most also severe complications that can occur, which I'll talk about the classification as well, is a brachial plexus avulsion with a scapulothoracic dissociation injury. Here is some imaging for the brachial plexus that shows a short tau inversion recovery hyperintensity and the roots from C5 to T1. And then on the right side here is a sagittal MRI stir image as well from the cervical spine that shows a epidural hematoma. So Cell et al., they modified another classification that was already in place for scapulothoracic dissociation injuries, and they created a widely referenced system that can be used in both to continue to do research on this injury and also in the evaluation of this injury in clinical settings. So they found that patients with brachial plexus avulsion had poorer functional outcomes. Here on this table, there's types 1 through 4. A type 1 injury is classified as the mildest form, and a type 4 injury is considered the most severe in a scapulothoracic dissociation injury. As you can see right here, a type 1 would just involve the musculoskeletal injury. As you progress through the different types, you could have also vascular involvement, as well as neurological impairment. And as previously discussed, type 4, it's a musculoskeletal injury with a brachial plexus injury. And these are my references. I do want to mention as well that for the management of scapulothoracic dissociation injuries does require a multidisciplinary approach. As you can see, you can have vascular involvement, you could have also neurological involvement. So if this is highly suspected and patients have these associated injuries, it's important for them to get either a surgical intervention that they need right away. I think that is all. Thank you so much.
Thank you. That was a really great overview. Especially since not all of us work in the, a high, level 1 trauma setting. I think it's great to kind of see that and reinforce kind of the findings. I know, at least for me, it's just one of those, for being such a severe injury, it's almost kind of one of my blind spots on X-ray where I really do need to trace like the scapulae and just make sure they do look symmetric, just to make sure I'm thinking about it. And it's one of the things I just have to force myself to think about it, which is always a little embarrassing. But I think for being severe, I think they can be challenging, at least before you get to the CT phase. We did have one question. It's yes, it's in the Q&A. Is there any chance that this is related to a winged scapula, or if you could maybe, I don't know if you kind of heard or thought about the winged scapula, if you had any, if you look when you're doing your kind of research and background, if you had any comments about how the appearance of a scapulothoracic dissociation would differ from like a wing, what people call wing scapular or scapular dyskinesia.
Yeah, so I haven't like looked up like in terms of like the difference between both of those, but that I do know it's particularly not related to a wind scapula, especially knowing I guess from my medical school knowledge as well, with the wind scapula is usually due to like impairment in a nerve. This one usually starts off with a fracture that then leads to vascular impairment, and then to that like brachial plexus avulsion. I hope that answered your question, but I can definitely give you more information as well.
I appreciate that. Yeah, I think that was pretty nicely stated, that scapulothoracic dissociations are truly essentially an injury or dislocation of the kind of the interface between the scapula complex and the rest of the chest wall. All right, and lastly, we have our final presentation is Amna Aslan.
Hi, everybody. Thank you all for sticking to the end. And I have a slight twist to MSK here by bringing in breast imaging. So I hope we have some breast imaging folks in the audience. And if not, this applies to everybody because MSK is everywhere. And we're going to see it on breast MRI right now. So extramammary findings are detected in up to 34% of patients on breast MRI, and a lot of these findings are MSK findings. And so today I'm going to go through a review of both benign and malignant findings that can be seen on breast MRI. All right, I have no financial disclosures. So our learning objectives, I will be describing a range of both benign and malignant musculoskeletal imaging findings by their imaging features on breast MRI. I will be identifying which imaging features and risk factors to look out for that might raise concern for malignant degeneration of certain MSK lesions. And we'll also be discussing different mineralization patterns of primary chest wall tumors and asking the question of what to do next if we see these findings on breast MRI, because that ultimately is what the question we're asking here is. So for figure 1, we have an axial T1 image on for A and a T2 fat saturated MR image. On T1, we see an iso-intense lesion, and on T2, we see a hyper-intense lesion in the sternum. And this is characteristic of a hemangioma, where we see a heterogeneous and enhancement on fat-suppressed images. So hemangioma is often seen within the sternum. It's composed of vascular elements with associated fat, but it may also contain fibrous tissue, smooth muscle, or bone. It's T2 hyperintense with intermediate to high T1 signal, and MRI is diagnostic, so no further workup will be required after we see this on breast MRI. Next, we have an axial T2 fat-suppressed MR image that's showing a mass projecting anteriorly from the left third rib here. And we see that it has a hyper-intense cartilaginous cap of the lesion itself. And when we correlate this with chest CT in image B, we see that it has a corticomedullary continuity with the adjacent rib. And this is characteristic of an osteochondroma. So osteochondromas consist of an osseous protrusion from a bone with an associated cartilage cap. It commonly occurs in long bones and sometimes within the ribs. And they have a less than 1% chance of malignant degeneration to chondrosarcoma, and the risk is almost 5% if it's associated with syndromes such as multiple hereditary exostosis, as we mentioned earlier on in this presentation. If they're also more than 3 millimeters, we might be concerned of degeneration, and that's when we can get further imaging. All right. And for figure 3, we have an axial T2 fat-suppressed MR image on the left, which shows a T2 hyperintense expansile lesion of the right fourth rib. And this is correlated with image B, that is a CT axial demonstrating a ground glass matrix appearance of the rib itself. And this is characteristic of fibrous dysplasia, which is also completely benign. It develops when immature bone and fibrous stroma replace normal Kanzel's bone as a result of abnormal differentiation of osteoblasts. It can be associated with McCune-Albright syndrome or Mazabrod syndrome, and common MRI features consist of an expansile mass with low to intermediate T1 signal, variable T2 signal, and variable enhancement. The reason why CT is so helpful for fibrous dysplasia is because it allows us to see that ground glass matrix or hazy material that we saw earlier. And if it's seen by a breast radiologist on a breast MRI, the next step would be to do the CT, because it helps just associate it with fibrous dysplasia, and no other further workup is needed. For figure 4, we have a axial short tau inversion recovery in image A, which shows a hyperintense intercostal mass that was pathologically proven to represent an intercostal schwannoma. And in image B, we have a different patient. This is a T2 fat-suppressed MR demonstrating a peripheral nerve sheath tumor. It's T2 hyperintense. It's a cutaneous mass in the lateral right breast. And this was in a patient with known neurofibromatosis type 1. So these are examples of peripheral nerve sheath tumors. Peripheral nerve sheath tumors arise from the chest wall in young and middle-aged adults. Intercostal schwannomas arise from the intercostal nerves or posteriorly from the spinal nerve roots. On MRI, they're isointense to slightly hyperintense relative to skeletal muscle. On T1, hyperintense on T2, and hence homogeneously, as we saw with contrast. And neurofibromas, of course, develop in younger patients, which is associated with neurofibromatosis type 1. In a patient with neurofibromatosis type 1, this is likely a secondary finding that you would expect incidentally, but they would probably already have the diagnosis. But with intercostal schwannoma, that might warrant biopsy to confirm the diagnosis. Great. In figure 5, for A, we have an axial T2 fat suppressed MR image, which demonstrates an acute fracture of a left anterior rib. And we see angulation, disrupted appearance of the rib. And of course, this patient had a history of blunt chest trauma. And this is in contrast to the images for the patient in both B and C. It's the same patient in B and C. In image B, we have a T1 post-contrast subtracted MR image through the sternum, which demonstrates a mildly expanding bone. It's heterogeneously enhancing, and this is concerning for metastatic disease. So the history of this patient is a history of breast cancer, and we see here that on the technetium 99 scan that this is enhancing, which is suggestive of metastatic lesion. And so the reason why I grouped these together is to basically help distinguish between a pathologic fracture and acute fracture. Oftentimes on MRI, they might seem similar, especially with the feature of edema around the bone. And so further imaging is necessary to rule out a pathologic fracture that may be secondary to metastatic disease. All right. In figure 6, we have in image A, we have a heterogeneous mass on T1 fat suppressed post-contrast image. And in B, we have a CT scan of that image. And what we see here is areas of low T1 and T2 signal that correspond with mineralization seen on CT. And this is referred to the typical ring and arc appearance of a chondrosarcoma. And in C and D, C is another T1 fat suppressed image of a heterogeneous mass, and we see the similar calcifications on CT, and this is indicative of an osteosarcoma. So just comparing these two, we know that osteosarcoma has more calcifications, and chondrosarcoma would have the ring and arc appearance, and that's how we can differentiate these two. And of course, these would require biopsy and further workup. In summary, chondrosarcoma is one of the most common chest wall malignancies, and on MRI, it appears has a low or intermediate T1 signal, high T2 signal, and avid enhancement. And we have the ring and arc appearance, as I mentioned. For osteosarcoma, it's the most common primary bone tumor, and it can arise de novo or secondary to malignant degeneration of fibrous dysplasia and or Paget's disease. And we can get further workup with CT and radiography to further classify the mineralization. So in conclusion, incidental MSK findings are incidental but very common, and it's important for radiologists to be able to identify these lesions, suggest a differential diagnosis, and guide management, especially if your breast radiologist colleague calls you up as an MSK radiologist. One needs to know what the next step is. And of course, there are further correlations with CT or radiography to better understand these lesions. So.
Thanks, Anna. That's a really nice overview of kind of the different abnormalities that we often see or are asked about, with these breast MRIs. You can see from the Q&A, it's a lot of people are kind of have are really affected or kind of have a strong interest in kind of how these incidental breast lesions kind of percolate to us. And I think it does highlight kind of the need to have a really engaged discussion with our mammography colleagues and kind of figuring out like the best course to ask. So one of the questions from the QA that I think was really pertinent was, does the standard breast MRI protocol include sequences that will make all of these diagnoses, and of the ones you've maybe listed, which are the ones you think would benefit for additional imaging or further workup with a different modality?
Yeah, that's a great question. I think definitely with some benign lesions like hemangioma, lipoma, you don't need further workup after it's seen on MRI. But with things that can be a little bit confusing, like fibrous dysplasia, for example, a CT is really helpful to visualize that ground glass matrix that we talked about. Similarly with, of course, your osteosarcoma, chondrosarcoma, that CT that we saw really helps see the calcifications better and helps characterize those malignancies. And so while breast MRI is helpful in detecting those incidental findings, it's not always diagnostic or conclusive. And so it just depends on the type of lesion. Usually the more malignant lesions or uncommon lesions will require further workup with CT or radiography.
Yeah, I think those are great points. I know for us, kind of part of the challenge is kind of like when we're asked to look at a prostate MRI. I know they're not typical sequences that we would use to kind of formally characterize lesions. So you're kind of trying to parse kind of somewhat incomplete information into one picture. But I agree that there are certain things that you really can't be able to kind of say, okay, I think this is a benign thing. Don't pass go. And there's certainly things that can really merit further workup. But that was great, and I appreciate it.
Great. Well, thank you, everybody. I want to thank the attendees in the audience. I want to thank all of the speakers for submitting your work and putting so much effort into it. I want to thank our moderators. And I think I speak for all of us MSK Rads that I'm kind of scared now that I've seen how good you guys are. So I better be on top of my game moving forward. So without further ado, I will name our most outstanding abstract of this. Again, it was a very close race, but in the end of the day, the award for best abstract in this first medical student research symposium goes to Regan Bayer for a novel radiographic parameter of anterior and posterior acetabular wall intersection with the dorsal and its correlation with surgical management. So congratulations, Regan, and we'll be in touch about next steps for you. Again, thanks to everybody for participating and really appreciate it. So that will be it for tonight's event, and we'll see you soon.
Bye, guys. Thanks so much. Great job.
Thanks.